Prior to announcing these inspections, HIQA sent out a communique number 4, and that was sent out on the 23rd of March earlier this year. And in that communique, they emphasised the need for a contingency plan in the following areas. So again, governance and management, staffing and infection control. During the presentation, HIQA emphasised the need for contingency planning to be dynamic and responsive to changing situations. So it was recommended that centres would have a plan A, a plan B, a plan C, a plan D. And I suppose this can seem somewhat onerous, but the practicalities of this are to do with the reality of the situation. So for example, in relation to staffing, in the current context of all the testing that's being carried out in centres, it could well be that a centre would find itself in a situation today that test results come back and a substantial number of staff are COVID positive. And that may not have been something that was allowed for in the initial contingency plan. So the whole idea is that the contingency plan would be updated and it would be dynamic, responsive to changes. In the framework itself, the first area that's mentioned is about policies and procedures. And again, in the presentation, HIQA emphasised the need for policies, procedures and guidelines to be reviewed and updated. It can be quite difficult to update all the policies and procedures each time there is a change to guidance. So it may be worthwhile doing up one COVID-19 policy that will cover all the main areas that will be affected by a COVID outbreak. So again, governance and management, staffing, infection control, resident care, and we'll go into those in a bit more detail in a minute. So with regard to preparedness, current measures need to be aimed at preventing, detecting and responding to cases. And one of the first things that people need to do is to arrange the centre into independent discrete zones. So according to the HSPC guidance, what's recommended is that the centre arranges into zones, and each of these zones is somewhat self-sufficient, so that there would be designated staff who would work in those zones and staff wouldn't be moving in between zones. And also, as far as is reasonably practicable, that equipment should be kept in those zones, so that, again, for infection prevention and control, that we're reducing the chance of transmission. There'll also be a need with these zones to identify and mark clean and possible contaminated zones. Now, what I mean by possible contaminated zones would be for those of you who haven't actually had any suspected or confirmed case, but you're looking at what's going to happen if you have a suspected or confirmed case. So at this stage, identifying and marking clean and possible contaminated zones, and they would be the zones where you have identified or you have in place at the moment discrete zones that are independent. The importance of early contact with support services has been emphasised both in the HPSC document itself, but also in so many webinars, including the webinar last week. And when we talk about those support services, what we're talking about is your community health organisation, palliative care services, psychiatry of old age, and gerontology services. So there's a repeated message coming across from the specialists and the experts in the area that they're saying, don't wait until you need these services. Contact them beforehand to find out what services they have available, what they will be able to do for you in the event that you have suspected, confirmed case, and outbreak of COVID, how you'll be able to contact them, and what services they will provide for you. It's also important to commence surveillance of staff at this stage, and that involves temperature checks of all staff coming on duty. So from a practical point of view, what that will mean is being able to roster and ensuring there's a roster there for somebody who will be able to do the temperature checks of staff in the morning who are coming on duty, but also staff at night. And this is on the presumption that rosters have been changed so that people are doing 12-hour shifts, which would seem to be what a lot of people are doing and makes sense in terms of restricting movement. Residents also need to be monitored very closely for symptoms. And we will talk about those symptoms in a few minutes, because what we have found from places, not just in Ireland, but residential care facilities and the presentation of older people who have had COVID, is that their symptoms are not typical of what we would see in the rest of the population. So the emphasis is on, again, monitoring residents for symptoms. That would at least involve vital signs and probably O2 stats twice daily. The reason for O2 stats and why I mention this here is because in some of the frequent symptoms that are seen in the general population, breathlessness, dyspnea, hypoxia can be seen. And although it's not typical of what we see in older people, again, it's about prevention and being vigilant. And in that same frame, we need to apply a low threshold of suspicion and act quickly if changes are noted. And again, as we move on through the presentation, I'll talk about that in a bit more detail. At this point in time, standard precautions are hugely, hugely important at any time, but particularly now, even if there's no suspected or confirmed case of COVID, standard precautions are very important. It's also important that there's training and updates for staff. So staff will need training on COVID itself, what to look out for in terms of symptoms, how older people might present, but also the standard infection prevention and control procedures, that people will get an update on those. And I am aware that this is mandatory training in healthcare facilities to be carried out once a year. But at this particular time, refresher training is very important, and particularly training and updates that are being provided by the Health Protection and Surveillance Centre and the HSE. And there are so many resources out there for that. So the HPSC itself, HSE, HSE Land have a range of training on infection prevention and control related to COVID for nurses, for healthcare assistants. So plenty of resources there. Another important thing that needs to be happening at the moment is the physical distancing and restriction of movement. And that would need to look at, perhaps with regard to staff, how can we create that distancing? So maybe staggering staff breaks, staggering meal times, and the same for residents. If you are currently not experiencing COVID-19 in your facility, I'm sure at the moment that you have already commenced physical distancing for meal times for residents. I know what some people have done is they may have extended out the dining room into another area so that they can allow for physical distancing, but also staggering those meal times. Essential visiting, hugely important part. And again, from the point of view of residential care facilities, I know in the private sector, this would have commenced early in March, and essential visiting in all residential care facilities has been implemented. So that means literally only those visitors who are essential. And it would be important to make a list of those as part of the contingency plan so that staff know who is allowed into the building and who shouldn't be coming into the building to visit. One area that has received, rightly so, a lot of attention is around visiting at end of life. And again, when we're talking about restricting visiting, we have to be very sensitive to the needs of residents and their loved ones. What the Irish Hospice Foundation has recommended is that we are particularly compassionate and sensitive to the needs. So some of the recommendations have been made is that we take an individualized approach to this, and where the resident and family members do want to meet up, that those family members are provided and supervised and helped with putting on appropriate PPE prior to visiting. But also, it's important that people be told that there is a risk and that they will have to self-isolate for 14 days following the visit. It may be possible in some places, depends on the layout of an individual facility, but it may be possible for people to actually enter the building and go to see their loved one without going through any communal areas or without meeting any other staff, but that will depend on the building. So it's looking at, again, what you possibly can do to prevent any transmission of an infection to any of the people involved where there's visiting happening. So I suppose in terms of the inspection itself, it is important for inspectors and for staff and for residents, for everybody really, that again, that we try and reduce the amount of time that inspectors have to spend on site. And in order to do that, the more documentation that you have ready for inspectors to see, the better. So I've just kind of made a list here of some important documentation. So for example, the contingency preparedness plan. There are references, resources already available, say for example on nursing matters, COVID-19 policy, which is available for anybody to download on the Nursing Matters website. Nursing Homes Ireland have also produced a template, a contingency plan template for those members. So any of you who are members of Nursing Home Ireland will be able to access that. And the HSE have also sent around a lot of resources to people and have a lot of resources on their website. Having your risk register available. So it's up to individuals whether you want to do up another risk register for COVID-19 or whether just to add those risks specific to COVID-19 onto your existing risk register. And there are a number of areas that should be included in that. So it's literally sitting down, if you haven't already done so, but maybe even to look at the risk register you have, and to sit down and really look at, have we caught up all the risks related to this? So I suppose the obvious ones would be in relation to governance and management. So for example, if any of the key managers or our COVID lead, for example, were unable to come to work or had to isolate, what contingency planning or succession planning is there for them? In relation to staffing itself, and staffing is going to be a big issue where there are outbreaks in centres and is already in a number of centres. So looking at, you know, what the risks are there and what are we doing to mitigate those risks in terms of bank staff, access to people who maybe have retired from the facility. But then when you exhaust those resources, what is the next step? And this is why it's important at this stage to contact your community health office to find out what will they be able to do in the event that you have exhausted your own resources for staffing and any contingency staff that you had in place. I think also actual and planned rosters would be very important. You always have them there for an inspection, but they're particularly important in this inspection because HIQA will be looking at, the inspectors will want to know, again, what your contingency plans are and what kind of staff you have on, but also how staff are being designated to the specific zones that we talked about. Policies and procedures we mentioned, so it may be, my own personal view is to have one COVID policy that covers all the main areas, because then that can be updated as updates come from the HPSC. And as we know, we can have changes happening every day in terms of the guidance. I think it'll be important also to have for inspectors records of COVID-19 training that has been completed by staff. And again, as I say, there's a huge amount of resources out there for training. HSE Land itself has a huge amount of training for different grades of staff. Also, evidence of staff updating. So the guidance comes out, and the guidance may change after a few days of people being updated. So how are people being kept updated as these changes in guidance are happening? So in the presentation given by HIQA, they talked about having daily briefings, or it may be that you're using memos, email, and so any evidence you have of how you're updating your staff and keeping them updated should be included, and to have records of those. Also, records of communication with residents and families. The importance of communication with residents and families during this time, again, is emphasised by so many different specialists and bodies, not least the residential care facilities themselves. So again, any records you have of how you communicated with residents and families, both at the beginning and how you're continuing to communicate with them as changes happen. So for example, in making changes, say for visitor restrictions or for changing the layout of the centre to zones, how were families, how were residents informed of these changes? So again, if there was a standard letter that went out to people, if there were emails that went out to people, any meetings that may have been held earlier on, to again have records and evidence of those for the inspectors to view. Also, evidence of communication with other service providers. So we talked a bit earlier on about the importance of making early contact with your specialists and your other service providers. So again, to include in that your pharmacy. So what communications have been made with the pharmacy with regards to how supplies will be accessible during this time and during the COVID-19 outbreak, with GPs. So what communication has there been with GPs in terms of what services they will be providing at this time, and other specialist services, as we mentioned earlier, gerontology services, psychiatry of old age, and your community health office. I think it also would be prudent to have a sample of care plans for inspectors, so that again, that they can see that you have been preparing in terms of resident care and looking at how the care of residents will be affected by changes in service, visiting, all of these things, how they're going to affect residents, and the restriction of movement. So again, a sample of care plans. Particularly relevant are those care plans that would include advanced care planning for residents who acquire COVID-19. So to be able to provide inspectors with some samples of care plans where discussion has taken place with regard to people's preferences and wishes, if they are or if they develop symptoms, or if they are identified as having COVID-19. So again, what are their preferences and wishes with regard to, say, if there's a need for hospitalization or end-of-life care. I think it's also prudent to provide a sample of care plans for residents that display behaviours that challenge those that have behavioural or psychological signs or symptoms of dementia, cognitive impairment, particularly because they may have difficulty in understanding and complying with standard precautions, with physical distancing, and so on. So again, it's to be able to demonstrate to HIQA that you have thought of these things and you have identified those residents who you feel will have particular difficulty, and how you'll be able to support those residents in complying with infection prevention control, in keeping themselves safe, and also keeping other people safe. I think it's important to mention here that there will be people that may have particular difficulty in understanding the need for infection prevention and control measures that are in place, and where the centre and staff will have to risk assess these residents in terms of the risks to themselves or to others. And if there is a risk, looking at what they can reasonably do. And that can be done through on site in the centre in terms of the existing care plan that's in place, what works, what doesn't work, but also that centres are aware that they can contact the gerontology services and psychiatry of old age where they are having difficulties and need extra help with that. And it has really, really been stressed that residential care facilities should contact these specialists if they need that help. Other documentation that would be important is your surveillance records for staff. So again, to be able to show inspectors records of staff temperatures, those surveillance records. Also, any surveillance records that have been maintained as per HPSC for any suspected or confirmed cases. Also, it would be important to provide inspectors with evidence of monitoring for compliance with HPSC guidance and the local infection prevention and control measures. So that may be simple audits that are done up, and I know, for example, that the HSE did do up a checklist that has been circulated to people, a daily checklist that can be used for centres to monitor compliance with infection prevention and control procedures on site.